Thank you, madam, for the introduction. Thanks to the organizers of DRS for inviting me here. So I think over the course of the day, you already listened to much of information about oral semaglutide and about CKM. So I'll be looking at how to transform CKM outcomes with oral semaglutide, and I've been commercially supported by Novo Nordisk for this talk. So we have been listening a lot about CKM syndrome. Just to clarify this a bit further, we know that we have been discussing about cardiometabolic syndrome, how things like diabetes, hyperlipidemia, and obesity can influence cardiovascular diseases. And we also been listening to cardiorenal syndrome, where there is a complex interplay between the cardiovascular system and the kidney in terms of causing various adverse outcomes. So cardiovascular kidney metabolic syndrome is in fact a combination of all these things put together. So it's a systemic disorder which is characterized by pathophysiological interactions between metabolic risk factors. This includes obesity, diabetes, dyslipidemia, etc. The cardiovascular, the CKD, the chronic kidney disease defined by urinary albumin or EGFR, and the cardiovascular system. And all this leading on to multi-organ dysfunction and high rates of adverse cardiovascular outcomes. We know that there are various stages of CKM. The first one is called the stage 0, where you don't have any risk factors for CKM or any of the cardiovascular risk factors. You have a BMI and the waist circumference which is normal, the glucose levels, the blood pressure, and the lipid levels are within normal. And then you have the stage 1 when you have excess fat in the body, which actually can contribute to an abnormal BMI or waist circumference. You could have a mild glucose intolerance, but not reaching a diabetes sort of stage. And then this is followed by stage 2, the metabolic risk factor stage, where you can have hypertension, hypertriglyceridemia, metabolic syndrome, type 2 diabetes, and moderate to high risk CKD. Then comes the stage 3, where you have subclinical cardiovascular disease, which is a coronary calcification. You can have a subclinical heart failure or risk equivalence like very high risk CKD, stage 4 and 5. Or you can have a stage 4, which can progress on to stage 4, where you have established atherosclerotic vascular disease like heart failure or atherosclerotic vascular disease, peripheral artery disease, stroke, heart failure, or atrial fibrillation. So one of the major things about the CKM concept is that people actually progress from early stages to late stages, from 1, 2, 3 to 4. And you have interventions at all the stages where you can prevent progression of the disease and prevent the patient from reaching adverse cardiovascular adverse effects. So we know there's a metabolic dysfunction which initiates the CKM syndrome. We have the chronic kidney disease, which is an amplifier of the CKM syndrome. And we have cardiovascular disease, which is the outcome of CKM syndrome. The question is, do we have something which is a solution for CKM syndrome? And we could consider the GLP-1 receptor agonist, which we now have in practice, as one of the solutions for CKM syndrome. And let us look at some of the data which I'm trying to present to support this concept. Now we know we have been working with GLP-1 RAs. We have been prescribing this for many years now. And we know that how it acts. It's got action on the blood vessels. It got action in the gastrointestinal system, on the pancreatic beta cells in terms of increasing insulin secretion and suppressing the glucagon, and we have actions on the central nervous system in terms of appetite regulation. Now, if you come to different aspects of CKM syndrome, more specifically how it acts, this is how GLP-1 induces weight loss through appetite regulation. It stimulates the POMC CART neurons in the hypothalamus, which reduces the hunger, which reduces energy intake and food cravings. It could have actions in terms of the neuropeptide Y and AGRP, where it improves the satiety, so it prevents overeating and has got altered food preferences. So this is something which acts on the initial stage of the CKM syndrome. We have the actions of GLP-1 in the cardiovascular system. It produces improved endothelial function. It reduces the vascular smooth muscle activation proliferation. These are atherosclerotic risk factors. It reduces vascular inflammation, and it produces a favorable lipid profile or the lipid accumulation, less of this lipid accumulation in the vascular endothelium. This translates for the patient to a reduced blood pressure, improvement in weight, and a reduction of HbA1c. All these are indirect effects in terms of CKM syndrome progression. GLP-1 RAs, independent of all this, has got an important anti-inflammatory effect. We know that inflammation plays a very important role in atherosclerosis disease progression, be it the adipose tissue, be it the blood vessels, the heart, or the kidney. And there are various mechanisms where the indirect and direct effects of GLP-1 in terms of preventing or reducing inflammation, which effectively translates into lesser blood glucose, lesser oxidative stress, lesser markers of inflammation, and reduced body weight. Now, when it comes to chronic kidney disease, how does GLP-1 RAs act here? As I told you, as the stages progresses, you will have chronic kidney disease in stage 2 and stage 3. Here it has got both direct and indirect effects. Indirect effects are very well known to us. We know the glycemic control the GLP-1 RAs can improve, the blood pressure reduction, the weight control. These are very indirect effects, and there are direct effects in terms of increasing sodium excretion, the natriuresis, and also reducing the kidney systemic and kidney inflammation and oxidative stress. We have direct data like the flows data to show that this in fact works in clinical practice and translates into better kidney outcomes in people with diabetes and early stages of chronic kidney disease. Now coming to cardiovascular events, there are various mechanisms by which GLP-1 RAs lead on to cardiovascular protection. And this includes the entire thing in terms of acting on multiple organs. In the liver, it reduces the hepatic steatosis, reduces the circulating lipid. I'll come to more details of that. In the kidney, it reduces the urinary albumin. We know that albuminuria is a marker of cardiovascular disease. It prevents the decline in EGFR. In the blood vessels, I showed you, it reduces the blood pressure, improves the microvascular coronary flow, atherosclerotic plaque stabilization, reduces inflammation in the blood vessels, and in the heart, it reduces the inflammation and improves the glucose metabolism. All this translates into various aspects of cardiovascular disease protection in people with early forms of CKM syndrome. Now, these are again the same in a lot of more same information, putting it together. It has got effects on the brain, it has got effects on the heart and blood vessels, in the liver, in the pancreas, in the kidney. So as you would see in this previous picture or the early pictures which I showed about CKM syndrome, each of this has got a role in the progression of CKM syndrome. And you can see as a modifier, the GLP-1 RAs acts as various aspects of the entire CKM syndrome spectrum. So how are these being translated to clinical guidelines? So if you look at the guidelines by various international bodies, you have the MASH guidelines, the MASLD MASH guidelines from EASL. This is the European Association of Study of Liver. And it is recommended at that point that GLP-1 RAs are the preferred pharmacological options for managing people with type 2 diabetes and obesity in a background of MASLD or MASH. The cardiovascular guidelines have put it in terms of to reduce CV risk independent of glucose control. It has put both GLP-1 RAs and SGLT2 inhibitors in that place. Coming to the kidney outcomes, the KDIGO 2022 guidelines, GLP-1 RAs are used for achieving individualized glycemic targets in people with diabetes and kidney disease. And also the ADA-EASD position statement putting GLP-1 RAs in an area where the preferred drugs in people with atherosclerotic vascular disease, and also to be used in people with atherosclerotic vascular disease or chronic kidney disease, irrespective of their glycemic control. So we can see that the GLP-1 RAs over a period of time has occupied various key positions in terms of the glycemic therapy and also for cardiorenal protection. Now coming to oral semaglutide, how it can sort of deal with metabolic dysfunction, and we look at the evidence that we have. I think this does not require much explanation. This has been shown in previous slide, but one of the previous talks. So oral semaglutide has been with us for a long period of time, and we know there have been numerous trials, clinical studies, and large number of patients getting exposed to oral semaglutide over a period of time. It reduces glycated hemoglobin by around 1.5% in comparison to comparator studies where the active comparator did reduce only by 0.9% and placebo by around 0.1 to 0.2%. When it comes to weight, there's an average reduction of around 3.5 to 5 kgs weight loss. And when it comes to patients who are having a high HbA1c of above 9%, there is a reduction of approximately 2% of glycated hemoglobin when you come to people with a high A1c levels. Coming to the pioneer group of trials where the oral semaglutide has been pitted against various other comparators that we use in clinical practice, be it monotherapy, be it empagliflozin, be it liraglutide, sitagliptin, or against placebo, you can see that consistently people who are on some oral semaglutide achieved at least an A1C percentage, 1% A1C reduction, and at least a weight loss of more than 5%. So this is a composite endpoint which has been more prominent in people who are on oral semaglutide in comparison to the other comparator molecules in pioneer studies. Now coming to individual cardiovascular risk factor reduction, be it the HSCRP, be it the lipids which are the LDL or the triglycerides or the systolic blood pressure in comparison to empagliflozin or in comparison to other comparators, oral semaglutide did have a definite edge. And in terms of waist circumference reduction, around 4.7 centimeter waist circumference reduction in comparison to the comparators. Now, what is the real world data on that? This is now oral semaglutide has been approved as the first line therapy for the management of type 2 diabetes in India. And oral semaglutide is now indicated in people with type 2 diabetes across various spectrum. One is people who are anyone who is with type 2 diabetes more than 18 years of age. It can be used as a first line therapy, monotherapy, or combination therapy with any other drugs. Special populations, that is people with CKD, people with hepatic impairment, and it has been found to be cardiovascular safe. Now coming to the real world data, the Pioneer Real India study, which is a large real world evidence. So here it's around 380 patients. This is not a randomized trial, this is an outpatient trial where doctors in clinical practice started oral semaglutide and followed up patients over a period of 33 weeks. So this based on the data collected from their OPDs and based on questionnaires. Doctors were asked why the patients were started on oral semaglutide. So 90% were started for achieving better glycemic control and weight control. The mean A1C was around 8.9% in this population. 1 in 2 patients had cardiovascular disease, so being a sort of preferred drug in people with cardiovascular disease. And 1 in 5 patients were started within 1 year of diagnosis. That means there are a lot of patients getting started on oral semaglutide very early in the course of disease. Now coming to the real world data in terms of A1C reduction, it's around 1.78% A1C reduction from baseline and around 7.23 kgs weight loss from baseline when oral semaglutide was started over a period of 33 weeks. I think my slides are gone. Excuse me. My slides are...
Get the slides back.
Yeah. Thank you. And now coming to a sort of subdivision where people with a baseline A1C of less than 9% versus more than 9% were compared. You can see that when the baseline A1C was less than 9, it's around 0.93% reduction in A1C. But if you start it for a person with an A1C more than 9%, you achieve something like a 2.5% A1C reduction, very close to the sort of reduction or better than the A1C reduction with insulin. Now coming to weight loss, again, you can see across the A1C ranges, whether it's more than 9 or less than 9%, you tend to have around 7.5 kgs weight loss also in these patients when they started on oral semaglutide. Now, I've gone through the slides just to explain that even in real world data, the sort of data that you see in clinical trials still hold in terms of both A1C reduction and weight reduction. And if you look at the data, you feel that a weight reduction seems to be much more in real world studies than in the sort of clinical trials that we generally see from the Western world. Now, if you look at which drug would you like to choose in a patient with high cardiovascular risk or with various factors of CKM syndrome, you can see that oral semaglutide ticks most of the boxes in terms of glucose reduction, in terms of weight loss, cardiovascular risk factors, pleiotropic benefits, and the risk of hypoglycemia. So thank you very much.
So I think we can play the video now. It's been rectified, the video that we couldn't see. Can you please play the video?
Every first begins with a bold idea. The exceptional ones in the world can't help but ask, what if? What if the seemingly impossible could become possible? 20 years ago, scientists at Novo Nordisk thought, wouldn't it be great to change the lives of the millions living with type 2 diabetes? GLP-1RAs were a powerful solution, but there was a catch. This delicate protein structure, however, could only be formulated in an injectable. This sparked a vision at Novo Nordisk, formulating the world's first oral GLP-1RA, a vision many considered far-fetched. To be the first meant confronting the digestive enzymes problem, the problem of them degrading the peptides. Protecting the peptide, that is, the semaglutide in the stomach, required more than incremental steps. It demanded a relentless exploration of every molecular possibility. Finally, the breakthrough came in the form of an absorption enhancer snack. Years of unwavering dedication, countless iterations, and exhaustive research later, we had our reward, oral semaglutide. Snack is a meticulously engineered enhancer, finally offering the shield the peptide needed. It was a pivotal moment where an impossible dream shaped into a tangible reality. The world's first peptide in a pill was here, a pill as mighty as a pen. From this point, the mission only accelerated. That's where Pioneer came in. A landmark clinical program involving over 9,500 individuals rigorously validated this oral formulation. Each data point was a testament to the scientific revolution and precision engineering that propelled us forward. For 15 years, we were driven by the belief that with relentless efforts, no scientific barrier is too great. That relentless pursuit culminates in Ribelsis, the world's first and only oral GLP-1 receptor agonist. A profound experience of what's possible when science dares to challenge the status quo. A game changer. A life changer. The power-packed pill which redefines diabetes management. 2.6% HbA1c reduction, 7.2 kilograms meaningful weight loss, and 14% MACE reduction.